We are not. You are not audible. Your mic is muted.
Good evening, sir.
Ah,
Good evening, sir.
good
My
evening. Go
topic is
ahead.
on physiology of neuromuscular. My topic is on physiology of neuromuscular monitoring. So it comprises of the motor nerve ending, motor end plate, and the synaptic cluster. The motor nerve ending, what we call as a presynaptic part, the motor end plate, which is a postsynaptic part, which contains a muscle membrane, and the synaptic cluster. Here, the basic physiology is whenever the impulse, either from the central nervous system, central nervous system, reaches the pre in the form of action potential. It triggers voltage-gated calcium channels and activates the zones of nerve terminals. It opens, so it enters the nerve terminals from the cellular space. Increase in the calcium load, interact with the proteins, and they stimulate the synaptic vesicles to fuse with the active zones and release the acetylcholine into the synapse. Now, the reach of acetyl, now the acetylcholine travels across the synaptic cleft towards the motor intake, and it binds to the nicotinic acetylcholine receptors and triggers the acetylcholine gated channels to open. Here, for every 2 moles of acetylcholine, it occupies the alpha to alpha subunits of the acid receptor. And the motor endplate on the muscle membrane is permeable to the sodium ions. In the melting potential at the muscle membrane from about -9 milliliters. This is called as end-plate potential. In skeletal muscles, the end-plate potential is strong enough to propagate action potentials over the surface of membranes. This potential is carried along the muscle fiber with T tubules and triggers the release of calcium from the sarcoplasmic reticulum. Acetylcholine in the cleft, it gets by the acetylcholine esterase enzymes. And there is also receptors in the presynaptic part, which also is the feedback system and it controls acetylcholine release. The difference between the presynaptic and postsynaptic acetylcholine receptors is the response to these receptors are different against antagonist actions. Coming to the neuromuscular, the main principle is to take the effect of neuromuscular blockade agents and the muscle rest after stimulation of its corresponding motor nerve is usually assessed here. Most commonly used nerve muscle movement is the ulnar nerve and adductor pollicis muscle. There are few patterns of nerve stimulation like single twitch stimulation, post stimulation, double burst stimulation, tetanic stimulation, and post tetanic stimulation. Before that, we use a peripheral nerve stimulators to assist this. This is a battery-operated device. It delivers a square current wave of 10 to 80 milliamperes for about 100 to 300 microseconds. Then 300 microseconds can exceed the refractive period of the nerve. Here it also calculates the intensity in terms of coulombs. Negative electrode or the black electrode, which is placed distant to the positive electrode. The proper skin preparations is done after cleansing and abrading the skin with a gauze. This will reduce the skin resistance. Using about the electrodes, we use about the disposable pre-gelled silver or silver chloride electrodes. The conducting area about 7 to 11 mm in diameter. Else the current produced will not be adequate enough to reach the nerves. The electrodes can be like surface electrodes or a needle type of electrodes. Coming to the sites, we need to choose the site appropriate to the surgery and the accessibility during the intra also. That is something called as direct muscle stimulation, which is characterized by a weak contractions without strain, which persists even at the deep blockade. This pattern usually occurs when the electrodes are attached to the muscle directly over when it is to be assessed. To eliminate this direct muscle stimulation, we need to place the electrodes topographically, which is anatomically distinct. The nerve and the muscle units to be chosen to avoid this. The criteria fits for this ulnar nerve and the adductor pollicis muscle, which is easy to access in the intra and can be tactile, visual, and objective means of stimulation can be seen. Other than that, posterior tibial nerve, posterior tibial nerve for flexor hallucis brevis muscle, which causes the flexion of the toe. And we also can use a facial nerve and the orbicularis oculi muscle or corrugator superciliary muscle to elicit the impulses. So methods of neuromuscular monitoring, it can be either clinically evaluated using the respiratory parameters and muscle functions, qualitatively assessed or quantitatively assessed. Coming to qualitatively assessment, it employs the peripheral nerve stimulator and assesses the visually or tactilely the response of the stimulated muscle. So coming to the patterns, single twitch stimulation, it is earliest and simplest method. The pattern here is a single electrical stimuli which is applied upon the peripheral motor nerve at 1 Hz to 0.1 Hz of frequency. Now the response is evaluated and here the response mainly depends on the frequency applied. The applications is it needs a reference value before the neuromuscular blocking drug administration, used as a component in the post-tetanic stimulation and as a 0.1 Hz single touch stimulation. Coming to Trainer 4, it was introduced in around 1970s. It has a 4 supramaximal stimuli for every 0.5 seconds. Each in the train causes the contraction. The top ratio is something called dividing the amplitude of the fourth response by the amplitude of the first response. Before giving the neuromuscular blocking agents, the trainer 4 ratio will be 1.0. After the administration of the neuromuscular blocking drugs, we can see the fade response and it gradually decreases, which is inversely proportional to the degree of the block. In depolarizing neuromuscular blocking drugs, there is no fade occurs, but there is a fade phenomenon in the phase 2 block. Applications, clinical relevance about the onset, surgical relaxation, neuromuscular recovery obtained, can you see? And it is less painful. Limitations of train of 4 is overestimation of the neuromuscular recovery can be seen, and it does not allow the clinicians to quantify intense and the deep levels of neuromuscular blocks, which can be only done by the post-tetanic counts. Other than that, we also can't monitor the phase 1 blockade, which is depolarizing nerve blocks. Other than that, double burst stimulation, 2 short bursts of 50 Hz tetanic stimulation by 750 microseconds with 0.2 microsecond durations, each square wave impulses in the burst form. So here the individual which blend together and felt as a strong contractions. After blockade, the second response is usually weaker than that of the first response, corresponding to the drain of fourth fate phenomenon. And applications here, it is aimed to improve the clinical like visual and tactile detection residual neuromuscular blockage. Still, it cannot replace the objective type of monitoring. Coming to tetanic stimulation, 50 hertz of 5 seconds, one strong sustained muscle contraction and fade after tetanic stimulation is the basis for evaluation. But in coming to depolarizing block, response to tetanic stimulation is sustained. In phase 2 block, there occurs a fade phenomenon. So fade is something which is a presynaptic event. A large amount of acetylcholine are released immediately from the available stores in the presynaptic terminals. As the stores become depleted, acetylcholine release decreases until the equilibrium between the mobilization and the synthesis is achieved. Despite this, tetanic stimulation is maintained because acetylcholine release in more amounts than needed for the evoke response. But in case of neuromuscular blocking agents, margin of safety is reduced here. Which site is reduced? Which height is reduced with the fade seen, especially during the repeated stimulation. The tetanic stimulation has a sensitivity of 70% with a specificity of 50% and is also painful. Coming to post-tetanic count, here the pattern is composed of tetanic stimulation, which is 50 Hz for 5 seconds, followed by a 10 to 50 single twitches. That is post-tetanic twitches given at 1 Hz end of the tetanic stimulation, preferably after 3 seconds. This is a transient, exaggerated release of acetylcholine that shifts the ratio of acetylcholine and neuromuscular blocking agents and monitored end plate in favor of acetylcholine. It is not performed for more than 6 minutes. Mainly, this post-tetanic stimulation allows an assessment of intense degree of neuromuscular blockage detection. As the period of intense blockade dissipates, first response to post-tetanic stimulation occurs following a gradual return of post-tetanic twitches until first top stimuli reappears. So if in D blockade, we can see like 3 or less than 3 post-tetanic counts. When returning of top is most often occurs with a post-tetanic count is around 6 to 7. Coming to objective monitors, here we have a mechanomyography. Here it measures a isometric contraction of the muscle after stimulation of corresponding nerve. A transducer converts force of isometric contraction into an electrical signal. It amplifies and displays and it is recorded. This is a gold standard method of neuromonitoring, but still it is not used because of the bulk equipment. It also depends on the frequency applied and records the control responses. Coming to the electromyography, this is a very oldest technique. It records the compound action potentials from thenar and hypothenar eminence of the hand and also from the first dorsal and interosseous muscle of the hand when we use the ulnar nerve. Signals are usually picked up, amplified, rectified, and integrated. Other sites, what we can use larynx and the diaphragm. When we use larynx, we can go for electrodes, ET tubes containing electrodes. And in case of diaphragm, we can go for a paravertebral placement of electrodes at the level of T12, L1, L1, L2 levels, either right or left crest of the diaphragm, which is to be seen. So ideally, this evoked electromyography, it detects the electrical changes in one or more muscles. Mechanomyography detects the excitation contraction coupling and the contraction of the muscle walls. So pitfalls, electromyography is not always reliable. Improper placement of the electrodes can lead to inadequate pickup of the signals, and it also can pick up the signals from nearby impulses also. It do not return to the control value. And most importantly, it is very highly sensitive to the diathermy. Coming to accelerometry, this is based on the Newton's second law, force is equal to mass into acceleration. Here we are keeping the mass as a constant, which is thumb. The force is directly proportional to acceleration in that cases. Here it uses piezoelectric ceramic wafer with electrodes on both sides. Exposure to the electrode through a force, it generates an electrical voltage proportional to acceleration of the electrodes. Example like on ulnar nerve stimulation, the thumb moves. This is the simplest method which can be used in OT and ICUs, and it provides a very good correlation between the torque ratio measured from accelerometry and electromyography. Coming to kinemyography, this is based on the principle that stretching or bending a flexible piezoelectric film in response to nerve stimulation, it generates a voltage which is proportional to the amount of stretching or bending. Coming to cuff pressure modality, CPM, this detects changes in the cuff pressure due to muscle contraction. Here, the electrodes are integrated into the BP cuff. It stimulates the brachial plexus at the humerus level, analyzes the changes in the pressures in the BP cuff, and displays them in the monitor. Coming to the compressormyography, here it measures the pressure changes in the handheld balloon. On ulnar nerve stimulation, force of contraction of the muscle in the hand, which is transmitted to the balloon, which is secured in the hand, can be measured. Other than that, we also have phonomyography. Here, what we use intrinsic low frequency sound of muscle contraction with the special microphones, which can be recorded during the nerve stimulation. So coming to evaluation, here we compare both the non-depolarizing muscle relaxants and depolarizing muscle relaxants. In non-depolarizing muscle relaxant, if it is intense block, which is a period of no response, this is typically like 3 to 6 minutes after a drug is given. Deep block is something like intense neuromuscular block followed by a period of deep block characterized by absence of torque stimulation. Presence of at least one response to post-tetanic stimulation can be seen here. In the moderate type of block, it begins with the first response of top stimulation appears, gradual return of all 4 responses of top stimulation. Good correlation is seen between the degree of block. If one response is detectable, 90 to 95% of receptors, acetylcholine receptors are blocked. If all 4 responses reappears in top, we can suspect like 60 to 85% of block has reappeared. Coming to recovery, return of the fourth response in the train of four is the recovery phase here. Good correlation. Good correlation can be achieved when we compare the stop ratio with the clinical recovery. So top ratio of less than or equal to 0.4. Here the patient will not be able to move or lift arm, head, and the tidal volume may or may not be normal. Vital capacity and inspiratory forces are reduced. With a top ratio of 0.6, head lift of 3 seconds for 3 seconds can be seen. Eyes can be wide open. The patient might be able to stick out the tongue. The vital capacity and inspiratory forces are reduced here. So this is not the ideal period. Top ratio of 0.7 to 0.75. Here the patient is able to cough, can lift the head for 5 seconds. Grip may be still low. The patient cannot sit without assistance. Tongue depressor test is negative. When the top ratio is more than or equal to 0.8, all the above mentioned features might be normal. Patient may have a diplopia, facial weakness, blurred vision, and fatigue. Top of more than 0.9 in electromyography or mechanomyography, 1.0 in acceleromyography should be needed to exclude all the residual blockage. In depolarizing neuromuscular blockers, in phase 1, there is no fade, no post-tetanic count occurs. The top responses, all 4 responses are reduced at same degree. In phase 2 occurs at the abnormal cholinesterase levels, which mimics that of the non-depolarizing muscle relaxation. That's all.
Okay. It's a very, very exhaustive preparation, which you may not find time to complete this answer in your exam paper. Okay? So you have only 20 minutes if we have give you 20 to 10 questions for 3 hours. You don't have time to write all about this. But anyway, it's a very well prepared, exhaustive answer. And